everybody. I would like to welcome our honored guests and speakers to this conference. And as you know in the schedule, we are going to start our sessions with this first session about neurocritical care. And I have the honor to introduce Professor Aaron Benzan. He's the chairperson of the Pediatric Intensive Care chapter for 2024, and he's the dean of the Indian College of Pediatrics. This is what is written here, but I know that I can't reduce it in 2 pages. For the sake of the time, I will give him the mic to talk about the outcome in neurocritical education.
Thank you, Dr. Hashim, and the Gulf and the Pan-Arab Critical Care team for giving me an opportunity and inviting me here to your wonderful city. So we have been here since last 3 days and interacting with all of your colleagues and conducting the NIV workshop, and it was an amazing response, and we had a wonderful hospitality. Thank you so much. So I would be speaking on the outcome of severe TBI in children. So I come from Chandigarh, which is north of India. So this is my city. So if you get a time or an opportunity, you are all welcome there, and we would be very happy to host you. This is my hospital, postgraduate institute, and on the right is my advanced pediatric center, and you can see the pediatric emergency board there. It's a 300-bedded pediatric center. So I have nothing to declare. So this would be the outline of my talk. So I would be speaking in the next 20 minutes on TBI and its management and outcome. So we need to understand the burden of traumatic brain injury in children. It is one of the common causes of morbidity, mortality, and emergency visits in pediatrics. It affects more than 3 million children every year. And US and in, I think, all over, you can see they constitute a lot of emergency and ICU admissions and also leads to a significant cause of mortality. And the most common, they're bimodal age representation in infants or toddlers and then in the adolescents. And males are more common in more than 3 years old. And in infants and toddler, it is more common because they are more exploratory and they can fall and have significant injuries. So what is the pathophysiology of the brain injury which happens? We know from our MBBS days that brain is a closed structure. It constitutes of 3 elements, the brain matter, the CSF, and the blood. And it lives in harmony inside the skull. But if there is change in any of these parameters, it can lead to decompensation and can lead to problem, and this is called as Monro-Gallery doctrine. However, the brain tries to compensate it with the phenomenon called as autoregulation. If you see that between the blood pressure of 50 to 150, the cerebral blood flow remains static or same as the body tries to compensate by autoregulation. But beyond these parameters, the blood pressure, if there is a rise in the blood pressure, the cerebral blood flow also rises significantly. And if there is a fall in blood pressure, the cerebral blood flow also decreases significantly. So this is a compensatory mechanism, but beyond certain ranges, it becomes decompensated, and that is where the problems start occurring significantly, and we don't want it to happen there. So coming to the management of TBI, it starts from where the injury has occurred, and it starts at the periphery, and manage well at the periphery can lead to significant improvement. So we need to assess the airway, breathing, and circulation, provide good oxygenation and ventilation, assess any ongoing losses. We have to avoid the hypotension and hypoxemia. Hypotension is more detrimental than hypoxemia in these cases, and it has been shown that a combination of hypotension and hypoxemia can lead to 14 times more mortality than if they are present individually. So these things, if managed, can be easily managed at the peripheral health center or in the peripheral emergency. So if you can provide some good fluids, good bag and mask ventilation to prevent hypoxemia and hypotension, you can do a lot of help to the patient. So for this, at the periphery, one needs to control the bleeding. You can give a crystalloid fluid, avoid the colloids, so crystalloids are good enough. Don't target hyperglycemia, so don't give high dextrose fluids. We don't target ICP-directed measures in the periphery. So we avoid hyperosmolar agents or hyperventilation at that setting when it is uncontrolled. Then once stabilized, transfer to a pediatric trauma center with cervical spine immobilization, which is very important. Once the child comes to the emergency, we can intubate, use a advanced trauma life support protocol for this management, give good fluid resuscitation, do a detailed neurological assessment, including the Glasgow Coma Scale score. So this TBI can be divided into 3, mild, moderate, and severe. So mild is anywhere between GCS of 14 to 15, which is most common injuries which happen in the pediatrics. So 80 to 90% of the patients have the mild TBIs, fortunately, and they recover well. So we don't need neuroimaging in those cases because they recover well, and we do it only in occasional cases. Asymptomatic, if a patient is asymptomatic, you observe for a few hours and can be discharged. But if there are significant injury to the other organs of the body, a loss of consciousness, or it is a deteriorating sensorium with severe headache, intoxication, skull fracture, or others, you need to admit the patient at that stage. Moderate TBI with a GCS of 9 to 13. So they are approximately 10% of the patients, and the initial management is same. And here we need a neuroimaging and non-contrast CT scan. Fortunately, these patients also improve well and they have a good recovery. When do we do a word about CT scan or neuroimaging, and when should we do it? Because in traumatic brain injury, any bleed or any midline shift or anything can only be diagnosed reliably by neuroimaging, and that is CT scan is the easiest done. There are certain clinical decision tools or rules available which will tell you or guide you, because we don't want unnecessary overload to the system and also unnecessary exposure of radiation to the child. So these rules can help you guide that which child should undergo a CT and which should not, so we can avoid unnecessary CT scans. So there are few rules like pecan, catch, and chalice, so they are there. So you can use these rules, especially in mild to moderate TBIs. So this is one of the study which has compared the whether these how do they can guide us, and they have shown that clinical examination and the pecan tool has identified almost good number of children who needed, whether they need CT scan or not. So these tools are very handy and can help you in deciding the need for neuroimaging in these cases or not. So this was again one of the systematic review which has shown that the pecan is most consistent and has a sensitivity of almost 98%, though with a lesser specificity. But here we need more sensitive tools to decide about the neuroimaging. Now coming to severe TBI, which is the GCS of 3 to 8, and which is the most dangerous and can lead to problem. So the pediatric trauma TBI guidelines have in 2019 have published some guidelines in PCCM 2019, and most of the guidelines in these have weak strength of recommendations because we don't have much data available in these patients. We don't have well-designed RCTs. But what has been said and has been shown that if we follow these guidelines, it is associated with improved outcome and mortality. So the crux in this is the acute surgical management. Get a CT scan after initial resus and stabilization. If there is a mass effect because of the hematoma, you need immediate evacuation. If there is a midline shift that is more than 5 mm, it is significant. And repeat imaging may be required in few cases once the child has been stabilized and undergone, or you have kept him under observation. So respiratory monitoring, ABC, it all starts with ABC. So adequate oxygenation, like I said, is very important. We don't want tissue hypoxemia and hyperemia, because that may also increase your ICP. So target your PaO2 between 90 to 100. Hypercarbia is bad, so we don't want CO2s to rise. So anywhere between 35 to 40 is good enough for us. So target PEEP to FiO2 so that your FiO2 is less than 0.5, and minute ventilation to achieve your target CO2s and O2s. Shock can occur in multiple ways. It can be hemorrhagic, it can be distributive, or it can be obstructive because of tension pneumothorax. So you have to treat it accordingly and aggressively. If it is requiring more fluids or blood or any vasoactive agent, so that need to be started. And hypotension is a single significant factor for morbidity and poor outcome and mortality. Target normovolemia. Fluids are important, so give 75% maintenance fluid once you have given him certain fluid boluses. Keep a neutral fluid balance. Target urine output of more than 1 ml per kg per hour. Don't fluid overload the patient. In the first year therapy, head of the bed should be elevated to 15 to 30 degree and head should be in midline. So that will improve your flow to the brain and will also prevent reflex raised ICP changes. Sedation and analgesia is again an important factor in this, because pain is a significant stimulus and it can increase multiple times your basal metabolic rate. It can also increase your sympathetic tone, which can increase hypertension and bleeding from the injury sites. So also, it will also control sedation will control your ICP and will help in decreasing it. So decrease the cerebral metabolic rate with in good sedation and analgesia, and thereby it will decrease your cerebral blood flow. And a combination of benzodiazepine and opiate is good in this group of patients. Nutrition, which is often neglected in pediatric critical care, but is an important component, as it has been shown that it is associated with improved clinical outcome in pediatric TBI. Various studies are there. Hyperglycemia can occur in the first 24 hours, but severity or hyperglycemia is associated with mortality, worse outcome, and increased length of stay. So we should avoid that. Similarly, hypoglycemia should also be avoided in this. So maintain euglycemia in this group of patients. So this is a study on the nutrition in which has shown that nutritional support within 72 hours is associated with favorable outcome after severe TBI in children. This is an RCT published in 2018. It has shown that it has got a good outcome if the nutrition is properly taken care of. Then the most important is the ICP monitoring, because intracranial hypertension is the leading cause of death. So ICP monitoring can result in significant improvement in mortality if the patient has a low GCS. We can use an intraparenchymal or intraventricular catheter, and we target an ICP of less than 20 and CPP of 40 to 60 in this group of patients. There can be two pathways, whether we target the ICP or maintain the cerebral perfusion pressure. Cerebral perfusion pressure is equivalent to the mean arterial pressure of the body that's maintaining the blood pressure. So you target the perfusion pressure to the brain more than 40 or 45. For that, you need a good intravascular volume and target your mean arterial pressure. And with targeting the CPP, you can tolerate minimal raised ICP, because if the perfusion to the brain is okay, then mild rise in ICP may not be harmful to the patient. So we did a study in our unit, a randomized controlled trial published in Critical Care Medicine, that comparing the CPP targeted therapy versus ICP targeted therapy in children with raised ICP, and found that the survival was better in the CPP targeted group versus the ICP targeted group, and it was quite significant. And the patients who recovered in GCS or neurological recovery was better in the CPP arm versus the ICP arm. Similarly, the PICU stay was significantly less in the CPP group than in the ICP targeted group. Transcranial Doppler and role of transcranial Doppler in the ICU in these group of children has again showed that transcranial Doppler can adequately predict your cerebral perfusion pressure if you are not measuring the ICP, invasive ICP is not being monitored. So this is again a study which has shown that the non-invasive way of measuring the cerebral perfusion pressure using transcranial Doppler, and it has got a good correlation with invasive ICP monitoring. We again did a study in our unit in the role of optic nerve sheath and transcranial Doppler in raised ICP patient published in PCCM. And we found, and we also measured the intraparenchymal ICP and measured the ONSD and TCD in this group, and we found that a optic nerve sheath cutoff of 4 millimeter had a good sensitivity and a reasonably okay specificity in this group of patients. So they correlated well with the raised ICP when we use optic nerve sheath diameter in these raised ICP patients. Then hyperosmolar therapy to treatment. We have two drugs, the mannitol and 3% hypertonic saline. Mannitol was initially used significantly in all these TBI patients, but now hypertonic saline has come up and people are more inclined to use hypertonic saline because it has found to be more stable and useful with lesser side effects. We did another RCT in our unit on comparing mannitol with hypertonic saline in children with raised ICP, and we found that children who had the hypertonic saline, the fall in ICP was significant and early and more sustained in the hypertonic saline group than in the mannitol group. Similarly, the CPP was much better in the hypertonic saline arm than in the mannitol arm. And the change in ICP was also better, and change in CPP was also better in the CPP group than in the ICP targeted therapy. So these all were quite significant. The results were better in the hypertonic saline group. Do we need anticonvulsant prophylaxis? So seizures can occur in up to 30% of these patients, especially in younger children, and if they do occur, they have a worse outcome. And we need anticonvulsant to prevent early post-traumatic seizures, that is, which occur in less than 7 days. So in these groups, the anticonvulsant, anti-epileptic therapy prophylactic is good enough, but they do not play any role in preventing the late post-traumatic seizures, and continuous EEG also can guide you in that. So we'll speak about that in the next lecture. So this is about the post-traumatic seizures following pediatric TBI. So this was done in US, in which they had included all patients of TBI. And they found that it can occur in almost 1% children with TBI can develop post-traumatic seizures, early post-traumatic seizures. So giving anticonvulsant therapy can be useful in these group of patients. What do we do in refractory intracranial hypertension? Once you have exhausted your first therapy, so almost 1/3 or 20 to 40% can develop refractory ICP. So the options available with you are decompression, high-dose barbiturate coma, hyperventilation, lumbar drain, and moderate hypothermia. So we don't have significant trials or RCTs on this. But in decompression, there are some studies where they have shown contrasting results, varying from no change in mortality, but significant long-term outcome improvement in survivors. And some have said that they are effective if they are performed early and as not as a rescue therapy. So this is a systematic analysis published in 2019 of 260 patients, but they are mainly the case series. And they've shown that ICP has significantly decreased with the use of decompression. But mortality was looked only by 2 studies. One has said significantly decreased mortality, and other have also said that there is a decrease in mortality in this group of patients. And positive outcome has been said by almost 10 studies that long-term outcome is better if decompression is performed. This is the study from our unit in which we have performed a retrospective analysis of decompression. and there were 30 patients, and we found that the good outcome was seen in good number of patients, and means almost more than half had a good outcome when this decompression was performed. Barbiturate therapy is for significantly raised ICP. I'm finishing, just 2 minutes. And it can lower your ICP, but they have no use in decreasing the mortality, and also has significant side effects associated with it, which you need to be careful. Hyperventilation is reserved only when you have acute herniation syndrome and significantly raised ICP, and it has to be given for short term and not for a long continuous period. There have been various trials on therapeutic hypothermia with the concept that it decreases your cerebral metabolic rate and decreases your seizure threshold. As they have also shown that fever is associated with poor outcome, and each degree drop in temperature can decrease your metabolic rate by 6 to 8%. But studies in children are unequivocal. They have shown no benefit, but in fact, they have shown some harm if extreme hypothermia is applied. And also, rapid rewarming adversely affect the outcome. So this is again still on a trial basis. So coming to the outcome of these patients, fortunately, most children do well and mortality is low. But pupillary response at admission, occurrence of hypothermia in these children, and mechanism of injury is associated with survival and outcome when they present to you. A severe TBI or a GCS of 3 or 4 has the worst outcome, and they can have also poor long-term deficits and sequelae associated with it. And they can also lead a lot of burden on the caregivers and the family. So this was again a study from published in Frontiers about the outcome in middle-income countries and high-income countries, the comparative analysis. So it has been shown that in the middle-income countries, the impact is much more than in the high-income countries. So I would like to summarize in the end that TBI is a broad spectrum, and severe TBI is associated with morbidity and mortality, but a systematic approach can help. And following these guidelines can also improve your outcome. So this is the algorithmic approach which is available by the Brain and Trauma Foundation, published in PCCM for everybody's reference. So this is for refractory raised ICP, but all therapies are available, which I have spoken already on this. So thank you so much.
Thank you so much, Professor Aaron. We'll keep that question at the end, if you don't mind. So we'll move to the next session, Dr. Rima Ajawi. She is a pediatric intensivist from Bahrain. She's a founder of Pediatric Critical Care in Bahrain, and also she's a board member in GCC Critical Care Society. She will give us a talk about neuroimaging for pediatric intensivists, tips and tricks. The mic is yours. Thank you.
Thank you very much. And thank you, everyone, for being here. Good morning. Dr. Hashim, thank you very much for inviting me to be part of this amazing conference and the organizing and the scientific committee for all this work and preparation. So as stated, we're going to talk about neuroimaging in the pediatric intensive care. We'll try to look into a bit of tips and tricks. So I have nothing to declare, actually, other than it's my birthday today. So we're trying to go through the indications of the neuroimaging and the pediatric ICU. What are the available tools? What do we have? What can we use? And how to optimize imaging techniques in specific conditions, what to use and when to use it. We'll try to look into some pitfalls and special considerations in some conditions, and we'll try to look into some clinical correlation between imaging and interventions. We'll look into the future. We'll see what do we have in the future, what do we have new coming, and I hope I can give you some points to take them home with you. All right, so this is, as we all know, using neuroimaging techniques is very important for diagnostic reasons, for a lot of cases. Professor Aaron just helped us with one of them, with the traumatic brain injury. We have so many others: neuroinflammatory, neuroinfectious, ischemic changes, stroke, or if we want to look and monitor what is going on, an injury has happened, something is there, we want to monitor and follow up, or look into complications that are happening due to one of the problems that is happening. So what do we have from available modalities? We're not going to talk about skull X-ray. It is totally out of fashion. Nobody uses it anymore. Not in a setup of PICU, definitely not. So what do we have? We have the ultrasound, which is ideal, specifically in infants with an open fontanelle. CT, the biggest one, the fastest one we have. It's best for acute trauma, for diagnosing hemorrhages and fractures. The MRI, superior for ischemia, inflammation, white matter assessment, and tumors. Less commonly, we have the nuclear medicine, and but it's still very important. We use it for metabolic and perfusion studies. So what do we have? How to choose? We'll go through each one of them slightly, see what do we have for and against each one of them. So as we said, the ultrasound requires an open fontanelle. It is very crucial. You see it in the premature, basically, age group. You see it a lot in the NICUs, and is mainly used for intraventricular hemorrhage diagnosis, monitoring, grading, and hydrocephalus. Why do we like it? It's cheap. You can do it bedside. It is safe, more importantly. No risk of radiation or exposure, and in good hands, it can give you similar, if not even better than CT scan findings. The same point is actually taking against it. It's operator dependent. So if your radiologist or who's doing the ultrasound is not very much familiar with the ultrasound techniques, or specifically in pediatric age group, then you're not going to get the results. It's age limited in the sense of if the patient's anterior fontanelle has closed or it's quite small, then you have lost the window. And most commonly, you will require a CT to confirm the findings. I have not came across any neurosurgeon who would depend on ultrasound findings to proceed for a procedure, at least not on the institutes that I worked in. So as we said, it can diagnose hydrocephalus. And not only diagnose it, you can keep on monitoring. So you can do it every few days, depends on the size, depends on the recommendation. You can see where is your patient going on, and when is the time to probably go ahead and do a CT scan to convince the neurosurgeon to intervene. And as Professor Aaron just mentioned, he has just spoke to us about the use of the ultrasound for cerebral blood flow, and that's also beyond the neonatal age where it can be used in the PICU. So I'm not going to talk much about it. Another thing is the hemorrhage, intraventricular hemorrhage, very common, and it is not only for diagnosing it, also grading it, depends on the amount of bleeding and the location of it. And we know that this is an important prognostication factor, as the mortalities and the long-term neurological sequelae change significantly from grade 1 to grade 4, where we have around just 5% chance of mortality and chance of long-term neurological sequelae from grade 1, going as high as 50% chance of mortality with around 90% neurological sequelae with grade 4. So this is specifically for prematures as a major guide of where and how much do you really want to push and continue with your management. The next one, CT scan. Why do you like it? It's widely available. Most hospitals do have CT scans. It is quick procedure and quick results, not difficult to read. Most of us can read the CT scans, actually. Actually, we have to, because to keep arguing with the radiologist and the neurosurgeons. The cost is reasonable, and as we said, it's excellent for acute diagnosis of acute hemorrhage, injuries, and also, more importantly, not only the hemorrhage, it can give you the different ages of hemorrhages, which is very important in cases of management and diagnosis, specifically with cases of child abuse, for example, if you have multiple different ages hemorrhages are there. Why we don't like it? It requires patient transfer. You can't do it bedside until now. You may require some sedation. The transfer of the patient might be a challenge if you have an unstable patient and might carry risk. The most thing and the worst thing that we don't like about it is the radiational exposure and risk. And we're going to talk about this a little bit more because it's very, very important. As pediatricians, before being intensivists, our major rule is prevention before treatment. So we really need to discuss this a bit. And is not the best in assessing white matter disease or superacute or hyperacute ischemic changes. As we know, the changes can happen in a CT. You will not be able to see them till actually a few hours. So the risk of radiation has been proven and documented in the literature. And a dose of, an accumulative dose of 50 to 60 milligray units has been proven to increase threefold the risk of brain tumors if you're performing a CT brain. And if the red marrow has been exposed, you have also a similar rate of increment of chance of leukemia. How much do we need to do this? I mean, to get this exposure? 2 to 3 scans of regular scans, a child will get that dose. And that is quite little if we look into it as 2 to 3 scans. So we really have to think wisely before we decide on keep on repeating our scans. This is mostly for the radiology department where you really, they need to optimize their pediatric protocols and within this. But if you're in a hospital or an institute where you don't have a designated pediatric units, this might be missing. So you probably want to work on this just to make sure that your patient is not getting the adult protocols where they have much higher exposures. So what are the important focus points that we need to know, look at, diagnose, be able to pick before our radiologists give us the report, and we need to discuss with our colleagues. So if we look into this, this is the pointer. Yeah, I don't know. Okay, fine. The pointer? This one? Okay. So if we look into this, we can see this bright thing. We have a bleed in here, and this is happening. This bleed is coming like a lemon shape. Okay. So this is basically, this is epidural bleed. The epidural bleed is commonly seen in the trauma cases, so commonly seen with associated skull fractures, so look for it. The most important thing about it is not only diagnosing the bleed, is the amount of pressure also that this bleed is causing over the brain. As we see in this image, the ventricle at this side has been collapsed completely, and it is actually, you have some midline shift. So this is something that you need to find out and work on. On top of it, this is an arterial bleed commonly, and you might be actually seeing active signs of bleeding while you're doing the CT. And this is another indication for earlier intervention and even closer monitoring. The other one, the other CT for a different patient, those are not our patients actually. This is a bleed where it is extending all around. Well, this is one is limited, usually limited to the sutures. This is extending all around. It has a semilunar shape, and this is a subdural hematoma. Again, with the CT, you will be able to tell the age of this. Is it acute, is it subacute, or this is a chronic? And depending on the patient's symptomatology and the CT findings, your next step or plan of management will be taken accordingly. Okay? So again, the pressure symptoms here are very apparent where the ventricles are collapsed and you have a significant, basically, midline shift. This is a patient of ours, actually. Those are 2 scans for the same patient, actually around 24 hours apart. This is a 7-year-old boy who presented to us with a history of headache and vomiting, and history of fever on and off, of 1-day duration, and history of fever on and off for the last 1 month. In a view of his clinical assessment and the history, a brain image was done, and you can see significant multiple intracranial hemorrhages has been noted. Okay. In view of that, there has been some midline shift, but it was minimal. So, but in view of the clinical presentation and the neurological, his Glasgow scale, he was intubated and shifted to the ICU. His CBC came to show basically a count of over 600 and basically a failure of all the other parameters, so he was diagnosed as acute leukemia. He was managed accordingly. At the same night almost, he blew one of his pupils. So his pupil became unreactive, one of them became non-reactive. So we rushed him again into the CT scan, and this is what we see. Okay, the bleed in here is all more or less the same as we can see, but there has been a little bit increase in the one down, with significant increase in the vasogenic edema around these bleeds, and significant midline shift. With that picture and the deterioration of the clinical picture of the patient, this patient was shifted for an emergency, craniectomy, decompressive craniectomy, and basically he did well after that. When we are diagnosing, you might have the same finding, but total different diagnosis. So when we look into the CT, we really need to understand what are we seeing. For example, in this one, we can see that the ventricles are quite big, but the ventricle shape has been distorted also. And on top of that, we have evidence of increased pressure within and CSF seepage within the white matter, giving these translucencies around the ventricles all around. And once you see your horns are seen in these low cuts, then this is definite hydrocephalus. Another CT scan with also big ventricles, but the shape is maintained. No evidence of CSF seepage within. And when you evaluate the rest of it, you can appreciate that the size of the brain all in all has been shrinking. So this is a case of brain atrophy where you really don't need to intervene. The last one is a congenital problem where you have all the brain is white, is full of fluid, sorry. There is almost nothing remained from the brain in here. So this is a case of hydranencephaly. Do you need to tap? Do you need to drain? That's a clinical decision based on the discussion with the family and where you want to go with it. A third one, and the most important note or point out of this CT is not the findings that have progressed within few hours in this patient. This is the same patient who presented after near drowning. As you can see, there has been minimal subtle changes between the white-gray matter differentiation and the initial CT. He was admitted. After a few hours, the patient clinical condition deteriorated significantly. Another image was done. And as you can see, it has blown. The brain edema became much more extensive, compression of the ventricles, the third ventricle is significantly compressed, absolute no space around the brain here. The main message out of this CT is not the findings here, it's not only the findings, is that you should not relax if you have an initial normal CT in patients who sustained possible hypoxic injury into the brain. You should keep you always alert. The most important thing, we need to pick abnormalities. Yet, on the other hand, we should not overdiagnose whatever we see. Especially in pediatric population, we have a lot of variation, and what is considered to be normal in a neonate might be completely abnormal in someone who's 2 years old. So even within the pediatric population, there's a lot of changes. So everyone reading a CT has to be familiar with these changes as age-related. If we see, So the first CT is an absolutely normal finding for a 2-month-old infant with a normal increase in the extraaxial space. While in the second CT, which is a CT of one of our patients, you can see the space is increased. Yes, she's also 2 months old. But what do we have? We have, at the left side, we have a significant loss. We have a loss of the normal shape contouring of the brain. We have a collapse of the ventricle at the same site. And the CSF, which looks clear in here, is completely turbid in here. This was a case of salmonella meningitis, actually. The neurosurgeons took this patient. They have evacuated all this pus, cleaned it up, and they put a catheter for us where antibiotic wash was done regularly. Artifacts can be really a major problem, and especially in our patients. Movement. So that's why patient movement can give you a lot of bad artifacts. That's why in the pediatric population, we may need to sedate them even for CT scans. And many other things can give us a lot of artifacts which can alter our quality of images and affect the diagnosis. The third one is the MRI. Examine the structure and the function of the central nervous system and don't forget the spine. There has been more than 100 different sequences used. Most commonly is the T1, T2, and the FLAIR. So many others. Why do we like it? It's a gold standard in detection of pathology. It's safe. There's no radiation in here. So that's great. Okay, images can be seen in multiple all directions, and it's the most sensitive imaging to test the brain. Okay, it is the only one where you can look into the function, where you can evaluate the function. So this is an extra tip. Why do we use it? Why don't we just standardize it? It's not that there are issues against it. Again, it needs mobilization. So again, you need to shift the patient. It's a long procedure. It's not like the CT where you can finish within a few minutes. You have 30 minutes minimum, 40 minutes. In the MRI, someone who's not stable, that's not the best. Okay, it requires for that, all patients most of the pediatric patients will require sedation, and that's an extra risk for the patient. Okay, it's not only long, it is not easy to read, unless you have, not everyone can read an MRI brain, not everyone can read a pediatric MRI brain. So even who can read an MRI brain might have difficulty reading pediatric MRI brain. So you really need a specialist to be able to give you that. Not all hospitals do have that. It's quite costly, the MRI machine. And you can't see calcifications really well in the MRI. The T1, just a small tip about that, like C is fat tissue sensitive sequence. So anything high in fat will appear bright and white. Anything less, and as the amount of fat gets less, it's becoming dark and dark. We have to remember in the MRI, the gray matter is always gray and the bones are always black. Other than that, things can change. So in T1, you have the CSF will look black because it's mostly water there, and the white matter will be appearing white. The reverse is seen in T2. So you need to know the differences so you don't mistake the abnormalities, you don't misdiagnose it. It is worse, it is more of a water-sensitive sequence. And so everything high in water will appear white, and it goes with different shades within there. So what do we need to know? We need to tailor our sequence. So we have to discuss it with our radiologists to know what they need to do. So they know, they need to understand what are we looking for to know what they want to do. So as, for example, the diffusion-weighted images are better to detect ischemia, while the FLAIR is better for the inflammation. And you can see how the same pathology appears completely different in 3 different, images or sequences.
You have 2 minutes more.
Sure, I'm almost done. We don't need to go through this. So just quickly, very, very simplified. If you have a patient in the pediatric ICU with neurological symptoms, what do we do? First, evaluate your clinical presentation. Always clinical presentation, okay? Is it an acute presentation? Yes or no? No, then consider MRI, okay? Yes, do you have an open fontanelle? This patient has, the fontanelle is open, then think of doing an ultrasound as a first step at least. If not, then you have to proceed immediately for the CT scan. What does the future tell us? What do we have? AI is the master of everything. It's coming in every single thing in our lives, so it is there too. So it can give us faster results and can give us probably even more accurate interpretation of our images, so we don't need to wait for the radiologist to give us the report. Portable images, they are already there. We do have portable CTs. They have been approved by the FDA, the portable MRIs. Yet there are still some issues with them. The issue of exposure of the surrounding patients, if this patient with the CT, or if you need to mobilize them all just to avoid that. And the MRI, the portable MRIs, the cost is really ridiculous. And it's still, the resolution is not the best. So take-home points. Remember that the modality of choice depends on the clinical context and the patient stability. What can you do? Okay? CT brain can be life-saving, particularly in trauma, but use it wisely. Think of the risk of radiation. MRI brain is the modality of choice in most chronic presentations, of pediatric and neuro conditions. Open fontanelle, always consider neurosonograms, and think well, discuss with your colleagues, discuss with the radiologist, discuss with your neurosurgeon or neurologist what do they think best that can give us an answer instead of wasting time doing different things. And those are some of the references that I've used. Thank you very much. This is a photo of the hospital, of my hospital, Salmania Hospital, the emergency entrance. This has changed a bit now. They have done an extension for the pediatric, actually, emergency, which we are very happy to have now. And thank you very much.
Thank you, Dr. Rima. Thank you, Dr. Rima, for this interesting lecture with lots of radiation. And now I will present Dr. Aaron with the next talk about the role of continuous EEG monitoring in pediatric patients.
Thank you. So I'm back again. So I thought Dr. Hashim will be bored with me for the last 3 days, but looks like he's not. So he wants. Okay. So in the next 15-20 minutes, we'll discuss about the role of EEG in PICU, another very important tool to manage, diagnose, and titrate your therapy in neurocritically ill patients. So I have no conflict of interest. Like I said, I come from Chandigarh. This is north of India. So this is the Advanced Pediatric Center, my hospital, and my outline of the talk would be based on what is continuous EEG, in what conditions we use, and how we can help in various conditions. And I will also talk on the quantitative EEG and its role, and what are the limitations of both. So what is continuous EEG? Basically, it is a continuous recording of EEG with videography. So it generates a tremendous amount of data, and the interpretation is important but can be difficult and can be time consuming also. Quantitative EEG compresses the EEG of long time into a short 1 day or a 1-page information based on the amplitude and frequency. So it is a condensed display. It gives you easier visual representation and can give you a very objective measurements. So these are the two differences between continuous EEG and quantitative EEG. We use the International 1020 system in which 21 electrodes are required for the continuous EEG, but in ICU we use limited electrodes or montages. We don't need all. We can use lesser also in these patients. So these are the 4 common indications for which EEG is done for a neurocritically injured child. The most common is detection of seizures, especially the non-convulsive seizures. Then evaluation of paroxysmal events. Prognostication is important in this group, especially post-cardiac arrest, and detection of focal or acute neurological changes if they are happening. So coming to the background assessment and the prognostication. How does it help in these patients? So we can see the baseline level of the brain activity with the EEG. It can also confirm the alteration or changes in the consciousness. We can determine whether the patient has the ability to cycle between awake and sleep state, so it can very accurately tell us. Reactivity of the brain parenchyma is important to assess, and this is also used to grade your depth of sedation. And with focal abnormalities like an bleed, stroke, or like herpes encephalitis, you get significant changes in the EEG in this group. So the background EEG tells you about, in real time, the brain activity and the functioning of the brain. So what is happening in the brain and realities. And severity of this background dysfunction is highly predictive of short-term and long-term clinical outcomes. And it's very commonly used in neuroprognostication, especially following the cardiac arrest, in or out of hospital cardiac arrest, so it can guide your therapies or prognostication. So in post-cardiac arrest, these are few studies, recent studies, which have said that severe background abnormalities in the first 24 hours, presence of burst suppression, a generalized slowing if it is there, and absence of reactivity or sleep architecture are associated with unfavorable outcome and is also associated with mortality. So these 4 things, if they are present, are dangerous and can predict poor outcome. This is another study in resuscitation published in the post-ICU resuscitation trial. This is a secondary analysis from a multicentric study from USA, in which they found that EEG background has shown significant outcome, correlation with outcome if changes are present, the changes which you have discussed. So these are the cerebral dysfunction grading scale which we can see in the EEG. It can be posterior dominant rhythm, predominant frequencies, state changes, reactivity, and continuity. So all these, if they can be graded into normal, mild, mild to moderate, moderate, severe, severe, and this is the ultimate. So these moderate to severe changes, if they are present, are associated with poor outcome. So one need to see these parameters in the EEG, whether they are present or not. Severe EEG background is also associated with higher ischemic burden on MRI. When it is correlated with MRI finding, it has shown that there is a lot of ischemia is also present if there is a severe EEG background changes are present. When they are combined, both the continuous EEG and MRI, it is predictive mortality, capability increases both in diagnosing mortality and unfavorable outcome. And the combined area under the curve is almost as high as 0.97 when MRI and continuous EEG are combined together. So subsequent use is in the detection and management of seizures. So it is the most commonly a common indication in pediatric ICUs, because neurological injuries in pediatrics have got a high chances of developing seizures. And it can also, because most of our children are under sedative and paralysis, so clinically it may be very difficult to identify seizures when they are paralyzed. So EEG plays a role in identifying them. And non-convulsive status can be as high as, seizures can be present in 20 to 40% of the children, and of these 40% have non-convulsive status. So that is quite a significant incidence in PICUs. So these are the various incidents of seizures in various conditions, like in CNS infection, you can have almost varying from 16 to 100%, in TBIs, in stroke, in hemorrhages, bypass, cardiopulmonary arrest, septic encephalopathies. So all these conditions can have presence of seizures in the ICU. So continuous EEG becomes important in monitoring the therapies. Then another terminology is the seizure burden. Seizure burden is actually the amount of minutes or the time the seizure has occurred in 1 hour. So let's say if a seizure total time is 20 minutes in 1 hour the seizure has occurred, it is called as 20 minutes is the seizure burden of that. So it said that seizure burden is independently associated with short-term outcome in critically ill children. And if the burden is more than 20 per hour, that is more than 20 minutes per hour, is associated with poor outcome. So seizures less than 20 minutes per hour, cumulative seizures less than 20 minutes per hour has got a reasonably okay outcome. So we can also measure the seizure burden in these cases. Again, lower seizure burden, less than 20% per hour, has got good outcome, but if it is higher seizure burden is there, then the poor outcome is more in this group of patients. So based on that study and also on the evidence, the American Clinical Neurophysiology Society in 2021 has said that the electrical seizures for more than 10 continuous minutes or for a total duration of more than 20% is in a 60-minute period is associated with poor outcome. Earlier, this seizure burden was 50%. Now they have come down to 20%. So 20% is equivalent to 12 minutes in 1 hour. So if you have a 12-minute seizures occurring in 1 hour, so it is associated with unfavorable outcome, and that is based on the evidence also, and now it has come in the guidelines also. What does the seizures cause if they occur? It causes worse neurological outcome, it increases mortality, and in patients with seizures, it has led to worse long-term and short-term outcomes are seen. So how long should we continue this EEG monitoring if it has been started? So we have to keep a balance between the risk of not detecting the seizures and also getting an EEG done, utilize some resources because of the machine and the interpretation, and there's an amazing amount of the data which is generated. But it has been said that over 90% of the seizures are detected within the first 24 to 48 hours in these conditions if they have to occur. So the American neurophysiological societies have said that minimum of 24 hours of monitoring should be done, but shorter or longer durations can be done depending upon the clinical scenarios. And there are certain risk factors for predicting seizures. They are the young age, if their child has clinical seizures prior to starting the EEGs, and presence of intraictal discharges. So they can have more chances of developing or detecting a seizure in this group of patients. These conditions also have their own limitations, the continuous EEGs. So what are those? You need to have an in-house technologist to put the EEG, to monitor it, to apply, and then to see whether any troubleshooting is there or not. You need trained professionals to interpret at regular intervals because it's a huge data. And these then findings need to be communicated to the clinical team on time, because if delayed, it does not have any meaning. Then you need to get the EEG report. Storage of such amount of large data, you need to have a lot of archive files with you. And the most important, EEG review is almost always retrospective because we need the real-time or on-time management. If the interpretation is not done there, then it is done later on, so may not be always handy because most of the fellows in the unit may not know how to interpret it. So based on these shortcomings, quantitative EEG came up in the ICUs in the big way, because in this the large amount of data is condensed and you can do a real-time monitoring of cerebral function and it is easy to use. And this use is growing from 34% in early 2010s to 50% in 2016 is what the evidence has shown to us. And this is one of the surveys from US and Canada in which they have seen the use of quantitative EEG. So if you can see here, it's almost 34 or 35% the incidence is there if the usage of quantitative EEGs. Here again, it's almost 38%. So what are the types of quantitative EEGs? It can be amplitude based or it can be frequency based. So these are the two things which are monitored by this. So what are amplitude based? So they use the envelope trends. That's the running average of waveform. It can be median based or the maximum amplitude which has occurred or the median time interval. So it gives you the range between 2 and 20 hertz and the amplitude variation is seen between these 2 and 20 hertz. Or it can also use the mechanism of suppression ratio. That is the percentage time the EEG signal is below a pre-specified amplitude consistent with suppression. Let us say that if during a 10-second recording of EEG, 8 seconds had maximum amplitude of less than 5 microvolt, then the suppression is 80%. So this is how they calculate based on the formulas, softwares integrated in them. So amplitude EEGs, you need at least 3 electrodes. You can place in either the biparietal or the bicentral region. So it can be placed in any of those. Traditionally, we placed on the parietal region, that is the P3 and P4, and one is the ground electrode. So these 3 electrodes are placed, and then this EEG signal is filtered to amplify the frequencies between 2 and 20 hertz. So on the x-axis, you see the time, and on the y-axis, you see the amplitude. So this is a 24-hour amplitude EEG condensed in one page, so it is very easy to see. And you can see that here the amplitude has increased. So the child was having some seizure in this period. You can see some activities happening in here, and you can see more red changes happening in these areas. Then there are frequency focus. The other is based on the frequency, so in which you see the 3 types mainly. The CDSA type, the alpha data ratio or asymmetry index. So we will discuss one by one. So CDSA is the color density spectral assay. So you see the various colors. So here you can see from here, there is sudden spike in this flame-like pictures in here. So this shows that the child is having seizures in this period when it has activated. The asymmetry spectrogram, again, you can see these shows the symmetry between the two hemispheres. So here there is activity is happening, so it is showing some seizures is occurring in this period of the time. Then again the alpha delta ratio, so some spike is happening here. So these are the various ways or the techniques in which you can measure it. So can we identify the seizures by the critical care providers? Do we need technologists or electrophysicians? So this study was done by Rishi from Canada, in which published in Critical Care Medicine, in which he has shown that the ICU fellows can very well diagnose this with good sensitivity, the quantitative EEG compared to the neurophysiologists. So in fact, they have done it better than the neurophysiologists in detecting the amplitude EEG, the CDSA. So they were good enough to diagnose the seizures using the quantitative EEGs. So it can be easily learned by the fellows in the unit. This was another study which from UK, in which they have shown that the implementation and early evaluation of quantitative EEG for seizure detection in PICUs, published in PCCM. So the PICU team had electroseizure activity was, they have diagnosed it in all the children who had the seizures, but they also overdiagnosed few of the children. But at least they did not miss any child with the seizures when they were using this quantitative EEG in this group of patients. So how does it help or benefit? You can do a timely recognition and treatment. You can diagnose focal versus generalized seizures. You can localize the seizure activity. You can also see how much long the duration of seizure had occurred. And CDSA is the commonly used technology in the ICUs, and it is seen as a solid flame pattern, what I had shown you in the pictures. So severe background patterns on the amplitude EEG associated with worse clinical outcome, and any 1 hour period in the post-cardiac arrest, in the first 24 hours post-cardiac arrest period, having quantifiable suppression is highly specific for neurological injuries and mortalities, is what is the data we have. And it's correlated with severity and outcome in acute hepatic encephalopathy also, and in other neurotoxicity syndrome. And it can also tell you about the trend of the disease severity and guide your critical care decisions or treatment therapies in these based on the EEGs. This also has some limitations, so it's not like a very full protective tool, because some normative data are lacking. We don't know the pediatric based data that what is normal and abnormal, though studies are coming up. And the other neuroactive medications, if the child is on some neuroactive medications, so what is the impact of those medications on the interpretation of these EEGs? And we have no guidelines on standardized reviewing and reporting. And many patterns are not studied extensively or not validated, and we don't have a formal training courses or programs available in how to interpret the quantitative EEGs in these patients. And you may miss the seizures if the ictal amplitude change is too small, because so much of data is compressed of many hours into one sheet. So smaller amplitude changes may be missed, or the seizure is too short, or the seizure is limited to a very small area. So if not interpreted, looked into properly, so you may miss those. So in the end, I would like to summarize that continuous EEG is a very good tool. It gives you real-time information. It's a non-invasive bedside modality and the gold standard for seizure detection. So all children with neurological injury should be undergoing continuous EEGs. And seizure burden of more than 20% is associated with worse outcome. So in post-cardiac arrest and encephalopathic patient, it can be a very good prognostication tool. And quantitative EEG use in PICUs is increasing. So thank you so much.
Thank you so much, Professor Aron, for this interesting talk. I can see now most of the ICU trying to get this kind of quantitative or continuous EEG in their units. So we'll come to the final talk in the neurocritical session today. Back to Dr. Arima, and she will give us a talk about innovative approaches in seizure management in PICU. Dr. Arima.
Thank you, Doctor. Good morning again. Okay, so as we said, we're going to look into the innovative approach in seizure management in the PICU. Thanks again, Professor Aron, because he made my life easy. You took almost around 20% of my presentation, and that makes my life easier. All right. So again, I don't have anything to disclose. So our learning objectives today, that we're going to go through the how to differentiate between acute symptomatic seizures versus status epilepticus. We're going to explore the recent innovation in seizure detection and monitoring in critically ill kids. We're going to review the new therapeutic approaches, including pharmacological and non-pharmacological strategies. We'll discuss emerging technologies for seizure management in the PICUs with the use of the AI and all the new basically devices and techniques. And we're going to highlight challenges and future directions in pediatric seizure management. So as an overview, seizure in critically ill kids are quite common. And the prevalence of electrographic seizures has been found to be up to 20% of PICU admissions. And that's a really, very big number. And the status epilepticus from that was up to 6.1%. That included the non-conclusive seizures too. Really still very big. I was shocked when I saw it. I did not expect it that high, actually. It could be acute symptomatic or status epilepticus. The short term, why do we worry much? Because of all the problems. We have the short-term mortality of status epilepticus ranging from 0.9 to 22% across all age groups, and that came from a recent publication in the States, so very advanced country. And on the other hand, basically in Nigeria, they had numbers which were more scary, up to 43% in specific age group. And we're talking about mortality within 30 days of ICU admission. That's really worrying. The main challenges are, as stated before, by Professor Aron, is the detection, difficulty in detection in sedated, paralyzed patients, and the high percentage of non-clinical seizures or subclinical seizures. And the risk of long-term impact, like cognitive dysfunction, remains also a major challenge which we want to avoid. So what is acute symptomatic seizure? Is usually a provoked seizure where you had a healthier child, did not have any other problem before, and then comes to you with a seizure. Usually related to an acute brain insult, whether a trauma or a systemic disease, whatever it is, directly in the brain or toxins all around the body. It occurs usually within 7 days of identified insult, and commonly it is self-limiting. It could be focal or generalized, and usually it is brief. We're talking about the acute presentation. We're not talking about the long-term effect, because that will depend on the outcome and the amount of damage that happens really to the brain, to the patient's brain after you manage them. So status epilepticus, as we all know, is a life-threatening neurological condition that requires immediate assessment and intervention, because we don't want to reach to any of what we've seen. We don't want it to reach into further or to cause further damage. The standard definition, as we all know, status epilepticus is more than 5 minutes of continuous seizures or 2 or more, or recurrence of seizure within that time without regain of consciousness. And this has been changed around 2015, where it was earlier defined as more than 30 minutes, but they found that by the time you identify it as status epilepticus, by that time, the damage has already, and you initiate your intervention, the damage will almost be there with no doubt. So it has been changed to 5 minutes. Big difference. Now, refractory status epilepticus gives us a time of 30 to 60 minutes where you have an ongoing seizures going on after sufficient dose of initial benzodiazepines or non-benzodiazepines as your first line of management has been already administered. The super refractory status epilepticus is an ongoing seizure activity after 24 hours where you have already initiated your general anesthesia, or if they reoccur after when you start weaning them. The NORS is the new onset refractory status epilepticus, and FIRES, which is a subcategory, is a febrile infection-related epilepsy syndrome. Okay. So what are the new things, what are the advances in the seizure detection that are coming now? The continuous EEG monitoring, we had a lot of talk about that just now, so I'm not going to talk much about it. Again, the real-time seizure detection is very important. And as we said, as Professor Aaron has mentioned, it's very crucial in non-conclusive seizures. The disadvantages, difficult to read. You need your neurophysiologist or neurologist to read it for you. The leads can cause pressure injuries, local pressure injuries. So another thing. Looking for the AI that can help us replace the neurophysiologist input in that, quicker interpretation, that would be great. Okay. So another type also is the amplitude integrated EEG, or what we call it the CFAM, the cerebral function monitoring. It's a more simplified, continuous bedside EEG monitoring, as again said, it's easier to interpret, commonly used in neonates. You see it a lot in the neonatal units, especially after birth asphyxia events. They'll be all placed on it, okay? And it's a useful screening tool. It's very important. It's a screening tool. We cannot use it as a solo, way of diagnosing seizures. Why? Because the evidence has told us that it has variable sensitivity and specificity among multiple studies. So, as we said, and there are the automated algorithms, they still need to be looked at to confirm their reliability. The other new thing that we have is the wearable seizure detectors. So instead of placing the EEGs, we have the smartwatches, we have the headbands, okay, and we have the biosensors which can be placed, and they can all be, hopefully in a future time, more integrated into the PICU monitoring and gives us actually a real-time also detection rather than having the conventional EEG. There are new anti-epileptic drugs that came into the markets, generally more recently. Keppra, as we all know it, is widely used currently, is becoming one of the famous ones to use. It's a second-line therapy that is used, and it works on the synaptic vehicle blockage protein binding, like the Brevicat. They both work on the same way, and this is a non-conventional way of working on controlling seizures, comparing to the previous or the old anti-epileptic drugs. It is widely used, as we said, and it is liked because it has fewer side effects. Still serious side effects, but it has been generally found to have lesser side effects compared to the old anti-epileptic drugs. The laxomide is a unique sodium channel modulator which works on the same old way of the old anti-epileptic medications, but it has been found to be quite useful in refractory cases. It has been found specifically to be safer in elderly patients with liver and renal dysfunction. It requires an ECG monitoring because it can cause heart block. And with that, it still has fewer drug interactions, which is one of the major problems that we have with all the anti-epileptic drugs in general. Again, as we said, it works on the same way as Keppra. The good thing about it, it has quick onset, better tolerated by the patients in general, and fewer psychiatric side effects compared to Keppra specifically. Other than the drugs, what do we have new? The genetic testing. Genetic diagnosis is becoming, we're more in the era of genetic or diagnosis and tailoring therapies towards what each patient requires based on his genetic makeup. Hopefully this is becoming even more and more. So when you identify specific genetic mutations, you can identify and target specific treatment for these patients. The targeted therapies, the CBD or the cannabidiol therapy is usually used for certain refractory epilepsies. Whether you use it purified or concentration, there is no consensus about that yet in the literature. The evidence has shown in a big meta-analysis done in 2018 that it is effective. It managed to reduce 50% of the seizures and 30 to 40% of the patient. Yet, these patients, almost most of them, had specific genetic disorders. So once you know your genetic diagnosis, you can help them in a better way. So out of the drugs, we have the non-pharmacological approach. The ketogenic diet is not new as an idea to be used in refractory seizures, but it has been used initially for the long-term, basically, control. Now it has been proven to be used for acute status epilepticus. So once you have the patient and refractory status epilepticus, you have a patient who is in your unit, you'll have to initiate it. You have to think of it and initiate it, okay? The international consensus recommendation for NORS, including FIRES, suggested initiating ketogenic diet in children with status epilepticus who did not respond to first-line immune therapy within 1 week since the onset of the seizure. And a lot go for after 48 hours, actually, from that. Whom do we think or should consider more? The younger the patient, patients with metabolic or mitochondrial disorders, or if you have a specific genetic diagnosis, then those patients most likely to benefit more. You use it whether enteral or parenteral, it doesn't matter. That did not see any find. And the use of it actually in other neurological disorders is becoming much more wild, even in brain tumors and traumatic brain injuries, even in sepsis, away from that. But this is out of our scope now. The neuromodulation devices, we're having a lot of them are coming out. VNS maybe is the most basically famous about them. And as you can see, it requires a small surgical procedure where a generator will be implanted under the skin, under the left clavicle usually, and the electrodes will be connected to the vagal nerve. This will give continuous low voltage, impulses which will be transmitted into the brain and to control the seizures. So not for the long term, during basically status epilepticus or refractory status epilepticus. The transcranial magnetic stimulation is a non-invasive model or basically a device which creates a magnetic and electrical field that is directed towards certain locations. It depends on your EEG location. If you have specific focal seizures, then it will work better in these cases. And a meta-analysis has been done on the 2015 by F.A. Ziller and his friends. They collected around 432 articles talking about the use of transcranial magnetic stimulation for status epilepticus. And after their filtering, they only found 12 were relevant. They came out with a conclusion of Oxford level 4, i.e. good cohort data or studies coming from good data coming from cohort studies. A grade D means inconclusive evidence to suggest a potential impact of seizure control with the use of repeated, transcranial magnetic stimulation for focal status epilepticus and refractory focal status epilepticus, okay? Though the durability and the sustainability of the results was questionable. For that, in view of this data, they could not recommend the use of it, and as usual, they advised for further studies. The third one is the responsive neurostimulator, Where it's a closed loop, theory of it is amazing, sounds really amazing. You have a closed loop implant in the skull, basically, where you have a continuous monitoring of the brain activity to detect any abnormal rhythm of the brain activity, indicating that it might go into a seizure. Once that is detected, it will send an impulse into the brain to stop it from happening. So it will actually prevent it or prevent the full development of the seizure itself. Theory seems, and again, this has been used basically primarily in focal seizures and refractory focal seizures. So the difference between all of them, as we said, we've went through most of this during our discussion. What is the evidence tells us? This is one of the biggest review articles that has been done looking into neurostimulation for childhood epilepsy. It was published on 14th of July, 2023. The VNS was the most extensively studied one, where we have one big randomized controlled trial. It showed 50% reduction in the seizure rates after long-term treatment. It was cost-efficient and it was safe. The deep brain stimulation was, they found mostly retrospective studies. Long-term safety was not well studied for this device. The responsive neurotransmission, they had small retrospective studies. The reduction rate was very variable from the reduction of the seizures, for example, here, was very variable between 31 to 100%. Big changes. Long-term safety, again, was not studied, but the good thing is that there are some pediatric clinical trials that has been already initiated. The transcranial magnetic stimulation, there has been 3 small randomized control trials. The results were inconsistent. It has been considered still safe, as we said, it's non-invasive too. And there has been a plan for a multi-center trial. So the future is coming with some probably more information and more data. So what are the new emerging technologies? We actually spoke about them. The use of AI in seizure prediction, our new machines for better, earlier, and faster EEG analysis. And so we will be more informed about the seizures as they are happening. And the closed-loop seizure control system devices that we spoke about, most of them, with brain implants, sensors for control. What are the challenges in all those new managements? Cost of everything is very high. The new anti-epileptic drugs, the AI tools, the neuromodulation devices are quite costly, all of them. So the availability and delay access for all this new advanced technology in resource-limited settings is a big challenge, remains a big challenge. Okay, the limitation of the confirming evidence about all these new technologies, specifically in pediatric trials, remains an issue, but the hope is coming, as we said, that there are some new trials are going on. So future prospects, expanding in the use of AI-driven seizure detection in the PICU worldwide, development of next-generation anti-epileptic drugs with improved safety profile, larger clinical trials to come in, and precision medicine expansion, genetic-based treatment based on genetic diagnosis. It can help, it can definitely help. And the take-home message from me is basically just to remember that accurate diagnosis and efficient treatment of seizure in the ICU can be challenging. Continuous EEG and wearable devices improve seizure detection in real time. The new anti-epileptic drugs and the precision medicine are reshaping the treatment strategies, and the non-pharmacological approaches like ketogenic diet and VNS are promising. AI and closed-loop neuromodulation are emerging as next-generation solution. Collaboration between neurophysiologists, pediatric neurologists, and the ICU team basically for a better outcome is always very important for all our patients. And thank you very much.
Thank you very much, Dr. Rima, for your talk. And now I will invite the speakers, Professor Aaron, Dr. Rima, for the questions and answers. We have 10 minutes. So, and we need a mic, please. يعطيك العافية. So now it's open for any question. Dr. مصعب, تبي?
Yeah, better.
وين سلم عليك.
Thank you, everyone, for these amazing talks. Professor Aaron, I have a question for you. You looked into the consensus guidelines for severe pediatric TBI, and although we know that there's a level 3 evidence supporting ICP monitoring in pediatric TBI, you did mention as well non-invasive multimodality monitoring. So what are your thoughts in our case, in our part of the world where neurosurgeons are reluctant to sometimes put in ICP monitors, and perhaps we're still not yet as capable as at the bedside for performing ICP monitoring. So what are your thoughts in terms of the effectiveness and the applicability of TCDs and the optic nerve sheath diameter measurements, and how practical are they in monitoring ICPs?
Yeah, thank you so much for an interesting question. That's always a debate because the gold standard is the invasive ICP monitoring. Fortunately, in my unit, we are doing the ICP monitoring at the bedside, and that is done by our fellows. I don't know how we managed it, but we are doing it. We had built bridges with the neurosurgeons, so they taught us, and then that legacy is now being carried forward. But I do understand it is not possible everywhere, not even in our country, where very few centers are doing at the bedside. The neurosurgeons are very rightly reluctant because they are very busy, and ICP monitoring has to be done immediately in case you have to monitor your therapy based on ICP levels. So non-invasive is then the next tool which we have. So in that, no single tool is a gold standard. So they have their own limitations, and they are all operator dependent. But if you do it as a context of multimodal monitoring, you club your clinical examination with EEG, TCD, ONSD, NIRS, and your other facilities if available. So we'll give you a reasonably good tool to use. Short of ICP, now we're using in my unit both ONSD and TCD, and the literature also say that they correlate very well with ICP levels. But the problem in ONSD is the cutoff values. The range has been from 4 millimeter to 5.5 millimeter of the pupillary disc, optic disc. So then what do we do in those conditions? I would say the trend is more important. It will help you guide your treatment. So you do it repeatedly. So we do ONSD minimum twice a day in acute cases. So you can titrate whether the size is coming down or it is going up, then your therapy can be tailored based on that. Because individual variations based on age in the size can occur. In my study, we found the size of 4 millimeter as a good sensitivity of around 95%. But there are few studies which have shown that 4.5 or 4.8 or 5 is also good enough. Less than that is okay. So there is no single answer to it, but yes, if combined all these together, it has a very good tool to monitor your therapy, and ICP monitoring is not always necessary.
Dr. Ayman, could you use the mic, please? Thank you. Thank you.
Sorry, just a follow-up question. You mentioned your ONSD, you do them twice a day potentially. How about the TCDs? How would you use them to guide your management?
Again, transcranial Doppler is operator dependent. So, but it has got a very short learning curve. It's very easy to learn and use it. So we use the middle cerebral artery, and we use the pulsatility index and the reactivity index in that. And those values correlate very well with raised ICP, and the changes are also instant and spontaneous with the treatment or with any decrease or rise in the invasive ICP. So can be easily done, and it takes very less time. Both ONSD and TCD doesn't take long to do it at the bedside, so fellows are not burdened. So I think that can be used, and it's got a good correlation. Carrie Lynn from Boston has published in 2021 or 2020, I think in Pediatric Intensive Care Journal, the nomograms for TCD for various age groups. So those are very handy.
Thank you. Thank you very much.
Any more questions? Yep.
Dr. Aaron, I want to ask you about, in cases of TBI, what about the use of muscle relaxant or avoiding suctioning to avoid coughing and increasing the ICP? Would there be a role of a prophylactic like muscle relaxant in the first few hours or first day?
Again, a very important but a very neglected sedation and analgesia in management of neurocritically ill children. Any pain stimulus is bad. It can cause huge spikes, and also the sudden spikes and up and down of delta changes in ICP are more dangerous than a sustained ICP. So we have to avoid this. So for that, we need to have a maintenance pseudoanalgesia. We need to target our sedation scores, pain and sedation scores. So we use comfort score in all our patients. So we target the sedation comfort score of less than 15. And whenever we have to use any pain stimulation, like any procedure, like suction or any invasive procedure is required, we give a further bolus of analgesia in these before pre-procedure. Muscle paralysis is indicated only if there is a lot of asynchrony with ventilation. So it will not prevent pain. So pain can still occur with muscle paralysis. So you need good analgesia and sedation, and paralysis can only top up for asynchrony for ventilation, which may be required in few conditions, not in all. We use it very occasionally.
Just to keep up with the time, this will be the last question for the Q&A session. Thank you.
So, thank you for your talks. My question is that a lot of patients who have TBIs don't come with TBIs alone. They have other injuries. So as a surgeon, I was trained initially in adults and I transitioned to pediatrics. We look at solid organs with impunity and we take them out when we have these patients with TBIs to prevent hypoxia and hypotension. But in pediatrics, a lot of these injuries you can manage non-operatively. So my question to you, and when you have a patient with a TBI and a solid organ injury, how do you manage between non-operative management of the abdominal injury and managing the TBI?
Yeah, thank you for this question. And it's very rare to have an adult moving into a pediatric. So we have pediatricians going on into adults. So thank you so much. So it's a very complex situation because obviously if in TBI, other organs injury can also happen, and it also happens quite frequently. So priority is to stabilize, hemodynamic stabilization. So that is the most important thing. You have to take care of ABC, you have to take care of hypoxia and hypotension. So you have to stop the bleeding points. It can be anywhere, mostly the abdomen or any limb injury or anything if they are there. That has to be taken care of, along with the brain and spine care. So you have to do spinal immobilization, you have to give the minimal stimulation, minimal movement, and you have to club all the therapies together. Like we do the surgeries, we do combined. So whether the GI surgeon can come or the orthopedic surgeon come together with the neurosurgeon, they do it all in one setting. So try to see, and it's a multi-team approach. So it requires an effort, but yes, it's a difficult condition.
I can see there is a lot of question here, but just to keep up with the time, we'll stop the Q&A section, but the speaker will be around, so you can just catch him in the break and ask him your question. So I think we can finish our neurocritical morning session today, and everyone will have a 10-minute break, and then we'll meet up with a cardiac critical care session, inshallah. Dr. Hashim. Thank you.
Thank you, everybody. 10 minutes?
10 minutes break, yep.
Okay, yes, please. So please be on time so we can finish on time. Thank you.
Thank you.
Thank you very much.